Yes, sir. So
Something different, a challenging one.
just for the continuation of that above discussion, sir. So on day one, I give patients three options. First is conservative, second is injection, third is a surgery. So start from the conservative treatment till the injections. After injections, patient get ready for the surgery. Okay, doctor, I want to go for the surgery. So there is no in the convincing patient if you are giving all the three options and start from the first, second, third options. Okay, so thank you, sir. Thank you, Sudhir, sir, for giving this me opportunity. I really obliged to all the IIA officials, Rajiv sir, for this opportunity to me. I'm going to talk on the radial sided tumor, which is causing the pain. So here is a very interesting story I would like to say to all of you, where the Vishwajit sir has left us. I'm continuing from there. So there is a 47-year-old lady. She had a radial sided wrist pain since last 1 month. She went to a very senior orthopedic surgeon in Kanpur. So the orthopedic surgeon has given some conservative treatment and splint and medicine for the 15 days, for 2 weeks. She returned back after 2 weeks. There was no benefit, nothing, no pain was not relieved. He again given medicine for the 2 weeks. So after 2 weeks, there was no benefit. Uh, Patient has same complaint, same problem. So that orthopedic surgeon has done X-ray, and he told patient that you go and meet hand surgeon. That lady came to me. The typically, what my habit is that I always examine the patient, then I see the X-rays. So when I examined the patient, there was typical tenderness over the radial styloid, as APL stress test was positive. And then I thought, why sir has sent this patient to me? She has decurvent stenosynovitis. She told, sir, there is X-ray also. Then I saw the X-ray, and this was the case. There was a lytic lesion over the distal end of the radius. There was not significant swelling or the bony hard lump over the distal aspect of the radius. I realized that whenever you have seen the patient who has a wrist pain, always go for the X-ray and get X-ray done. You may have some kind of surprise. So baseline of my talk is that I'm going to talk on the history, physical examinations. So whenever you have seen any patient who has pain, always note that the way is the pain. Is it this lump is painful or painless? What is the side? What is the size of the lump? And how is the chronicity of the pain, since how old he has pain? This pain is increasing or the same? The clinical examination is that to see the size, if it is mobile or it is fixed to the underlying structures. Seeing any kind of vascular changes or the venous skin changes over the lump, or there is a limitation of the adjacent joint. How is the neurovascular status? How is the vascularity? How is the sensation? Because whenever there is the lump is there, the patient may have a symptom of compressive neuropathy. And always don't forget to check the regional lymph nodes. So these are the basic investigations modules where you can do the clinical CBC, ESR, CRP to check, to rule out any kind of X-rays, X-ray, CT, MRI. Bone scan is also helpful to detect the osteoblastic response on opposed to tumor itself. PETs is useful to measure the metabolic activity of the tumor, and in the biopsy. So all the non-invasive mode of investigation should be done before the invasive, like biopsy. So what is biopsy is defined? This is the technique of harvesting a representative sample of the tissue without compromising definite. Open biopsy is gold standard for the any kind of neoplasm or the malignancy if you're suspecting to the bone, and its accuracy is more than 96%. The important thing regarding the open biopsy is that always put linear incision and always plan the future surgery, plan the incision or plan the future surgery where you are going to put incision. So if you put transverse, very difficult to plan the surgery, surgical incision. So always put linear incision, longitudinal incision, and in next time when you are going for the definitive mode of surgery, then always take out the scar of the biopsy. So these are some common tumors which is present on the distal aspect of the radius. There's a huge list, but there are a few commons. It's like giant cell tumors, ganglion, though it is painless. This chondrosarcoma, osteoid osteoma, and PBNS. Giant cell tumor is basically, it is the most common tumor, happens at the distal end of the radius. This is metaphysis of the mature of long bones. It expands to eat and may destroy. There's a high rate of the local recurrence. There's and perhaps as a benign aggressive tumors, but it can metastasize and it cause death. So most frequently it happened in third to fourth decades, and distal radius most commonly primary site in the patients with metastasis. So there is how to deal these kind of giant cell tumor present in the distal aspect of the radius. So if there is intralesional excision, reserving the joint is desirable. I mean that the local recurrence rate is 7 to 30%, and local recurrence reduced by the adjuvant chemotherapy. When you are this tumor grade is grade 1 and grade 2, when the cortex has not been reached or there is no soft tissue involvement, you can go for the intralesional excisions and as well as the adjuvant cryotherapy or the phenol. And if it is grade 3 or grade 4, where there is a soft tissue involvement is there or the cortical breach is there, then wide resection of the lesion with extensive joint involvement, there's pathological fracture or extensive cortical. So these kind of patients require reconstruction with bone graft or the fusion with osteochondral graft, and sometimes the vascularized fibula graft if defect is more than 6 centimeter. He came to me and there was the distal aspect of the radius was involvement, a giant cell tumor. So if you can see the MR pictures, there's a involvement on, if you see this X-ray, there's kind of soft involvement on this side. There's the tumor was extended on the volar side and the PQ muscle most probably was involved. So I did excision of the tumor. I have incorporated mark of the biopsy. I first took the biopsy, and when the report has confirmed that this is giant cell tumor, I excised the scar mark along incision is along the scar mark and excised the tumor, and I have translocated the ulna and fixed with and fused the wrist joint. So there's three mode of reconstruction of the distal aspect of the radius. Either you can do the translocation of the ulna, or you can use the fibula head for the reconstruction of the distal, for the reconstruction of the radius, or you can fuse the ulna with the wrist carpus bones. So here I have translocated the ulna, I have cut the end of the ulna and fused with the radius. What is the advantage of doing this? I'll explain later on. There is another case which as patient has a 48-year-old male, has right hand dominant, has a pain and swelling over the right wrist since last 6 months. And there's a core-needle biopsy was done, and that has shown that it was a giant cell tumor. And I put dorsal incision and we excised this. So you can see that the PQ muscle is there. So the capsule is the tumor is well encapsulated. And I've incorporated this PQ muscles and excised completely. And, this tumor I have reconstructed with head of the fibula. So you can see that there's a hockey stick in the lateral aspect of the knee. The important thing is that you have to protect the common peroneal nerve, which is along the head, along the neck of the fibula. And the other important thing is that always protect the ulna. And when you are, because you are taking out the head of the ulna, you have to reattach the collateral ligament. Collateral ligament of the knee, you have to reattach, so make a hole in the bone tibia and resuture the lateral collateral ligament, and always keep some cuff of the tissue over the head of the fibula, so that you can suture this cuff of tissue with the capsule of the radiocarpal joint. And I have fixed this head of the fibula with and reconstructed the wrist joint. So what is the advantage? What is the difference between two procedures, the ulna versus the fibula head? The ulnar translocation advantage is that this is single incision surgery. There is no need to go on the knee. It is less time consuming. This chances of non-union. The reason behind whatever the muscle attachment is present or the distal aspect of the ulna is intact. So the vascularity of the ulna head is intact. Uh, you can translocate the ulna and fuse with the radius, and you will have good pronation and supination to the, and there is less likely that you will have a non-union because the cuff of the vascular cuff of the muscles, they are attached with the ulna head, and the uh, uh, when you do the arthrodesis, it unites very well. The disadvantage of ulnar translocation is that you will lose the you will lose the flexion and extension, because once you have fused the wrist, there will be no flexion and extension. But the advantage is that you'll have very firm grip, rock solid wrist is there, and you can do the all kind of heavy activities. The advantage of the fibula head is that you will have the luxury of the movement of flexion and extension. But the difficulty with the fibula head is that there is always possibility of the graft resorption. It's extensive surgery and prolonged surgery because you have to do the dissection downwards also. And there's always possibility of injury of the common peroneal nerves and lateral collateral nerves. So doing microvascular reconstruction of the fibula head, taking free fibula graft and fusing with there, but that is also required the additional skill of the microvascular surgery. There's the second kind of tumor which can happen over the distal aspect of the radius is chondrosarcoma, which is most common malignant bone tumor in the hand. It is slow growing, painless, and around 26% of the patients has more than 10 years. It present in the fifth to sixth decade, and hand lesion do not normally metastasize. It's low-grade tumor, difficult to distinguish from the incontinent. So on the X-ray, I'll present this case. This she is a 65-year-old lady, has right hand dominant. She had lump over the right wrist since last 1.5 years. Some orthopedic surgeon has done excision, but it was incomplete. It has recurred within a year, and she presented to me. If you see the X-ray, is lesion on the carpal bones as well as the distal aspect of the radius. Scans and MRI of the patient, it is a huge lesion which was extending dorsally, radially, and the volar aspect. See, you can see this patient has a huge lesion which was extending dorsally, radial side. So I started with dorsal incision, but I was not able to take out because I have to go on the carpus. I have taken out proximal carpal bones also because it was involved the scaphoid and lunate. So I go on the volar side. I took I removed the tumor, excised it. The important thing is that we have to be very careful to protect the radial artery, ulnar artery, median nerve, ulnar nerve, dorsal sensory branch of the radial nerve, dorsal sensory branch of the ulnar nerve. So all the neurovascular structures should be, all the key structures should be protected. And I translocated the ulna and fused with the carpal bones, fused with the metacarpal. And osteosarcoma, though it is very rare, the incidence is 0.18%, but this is very dangerous, it's more common in the upper part of the proximal humerus. Hand lesions typically seen in older patients where there's metastatic lesions are there. So in radiograph, you can see the sunburst pattern, periosteal elevation, Corman's triangles, and the treatment is neoadjuvant chemotherapy is preferred, wide excision, amputation, surgical treatment is choice. There's no role of the external beam radiations. And in the last, I would like to highlight this. Some patient may have osteoid osteoma where the 5 to 15% of the lesions occurs in the hand and wrist. There's the lytic more frequent than the sclerotic lesions. These patients respond very well to the NSAIDs, and sometimes you require curettage and excisions, and radiofrequency ablation is also required. So I want to summarize that always get X-ray for any kind of wrist pain. Non-invasive investigation should be completed before the invasive investigations, and before tumor excision, always confirm with the biopsy, because the pathological report should be there in front of you before you are planning for the surgery. And the complete excision is the key thing, and always protect the neurovascular structure of the hand, because if it is a visceral tumor, it doesn't create any problem if you are cutting something more. But if it is hand tumor or the wrist tumor, you have to be very careful about the critical structures like all the tendons, blood vessels, nerves, because if you're protecting them, then your future function is going, it depend on that. Because if you injure the median nerve or the ulnar nerve or the sensory branches, then patient will have not the predictable result. Thank you so much. Thank you.